Today we'll discuss about the working length determination. So the determination of accurate working length and its maintenance during the cleaning and shaping procedure are a key factor for successful endodontic treatments. So according to the endodontic glossary terms, it is defined as the distance from the coronal reference point to a point at which the canal preparation and the obturation should terminate. And if you see what this reference point is, the reference point is nothing but it is site on the occlusal or the incisal surface from which the measurements are made, and it should be stable and easily visualized during the preparation. And if you see, it is the highest point on the incisal edge of the anterior teeth and the buccal cusp of the posterior teeth. So, in some cases, what happens is that there won't be a stable reference point because of the undermined cusps, or there may be fracture of the tooth. So, in such cases, what we have to do? That shouldn't be a question mark for us. So, for that cases, we have to reduce those undermined cusps and the restoration before the access preparation and make the stable reference point. Now we'll see a few anatomical considerations such as what is anatomic apexis. It is nothing but the tip or the end of the root determined morphologically, and whereas the radiographic apex is the tip or the end of the root determined radiographically. And coming to the major diameter or the apical foramen, it is the main apical opening of the root canal, and it is frequently eccentrically located away from the anatomic or the radiographic apex. And coming to the minor diameter or the apical constriction, it is the apical portion of the root canal having the narrowest diameter. And if you see this, here this apical constriction will just looks like a 0.5 to 1 mm short of the apical foramen, and it gives an appearance of the morning glory passing from minor to the major apical diameter. And coming to the most important part, that is the cemento-dentinal junction. Here it is a region where the dentin and the cementum are united, and it is the histological landmark, and it is always not necessary that the CDJ coinciding with the apical constrictions. Usually it will have a range of 0.5 to 3 mm short of the anatomical apex. So that is what we have to see, that CDJ is not always constant. Next, we'll see the significance of the working length. So, it determines how far into the canal the file has been placed and worked. So, within the correct limits, it plays an important role in determining the success of the treatment. And if suppose the patient having the degree of pain or discomfort, it is that due to that the proper care is not taken, and it may be over or under instrumented. So we have to take the proper working length to determine the success of the endodontic treatment. And if you see what are the consequences of the over instrumentation, is that it usually results in the pain and discomfort, and it also causes mechanical and chemical irritation to the periapical tissues. And in case of the under instrumentation, it is a level shorter than the actual length. Here what it causes is that it causes the accumulation of the debris apically, which impairs or prevents the healing. An incomplete apical seal also supports the bacteria, which lead to the poor prognosis of the tooth. So, now we'll see the different methods for working length determination. In that, we have the radiographic methods such as the Best's method, Bregman's method, Bramanthi's method, Grossman's formula, Ingill's method, Wayne's method, Cutler's method, radiographic grid, endometric probe, direct digital radiography, zero radiography, and the subtraction radiography. Whereas the non-radiographic methods include the digital tactile sense, apical periodontal sensitivity, paper point method, electronic apex locators. So in the radiographic methods, we'll discuss about the Grossman's method. In this, what is here is that it uses a simple mathematical formula to calculate the working length. That is nothing but the actual length of the tooth by the actual length of the instrument will give rise to the apparent length of the tooth in the radiograph by the apparent length of the instrument in the radiograph. So that's how the actual length of the tooth has been calculated. Next, we'll see the Ingalls method of working length determination. Here, for Ingalls method, the diagnostic radiograph used to estimate the working length to the tooth by measuring the tooth from the stable occlusal reference point to the radiographic apex and subtract at least 1 mm from its length, as the minor constriction is always present short of the anatomic apex. And you should compensate for the radiographic image distortion also. So this measurement is transferred to the diagnostic instrument with a silicone stop, which is placed in the root canal, and the working length radiograph is taken. So on the radiograph, measure the difference between the end of the instrument and the radiographic apex of the root. Here the tip of the instrument ends at 0.5 to 1 mm from the radiographic root apex. That's how the working length is established. But in case of the short of the radiographic apex by more than 1 mm, add this value to the earlier estimated length and adjust the stopper to the radiographic diagnostic instrument accordingly, and retake the working length radiograph. And if in case of it is beyond the radiographic apex, reduce the value from the earlier estimated length and adjust the stopper on the diagnostic instrument accordingly, and again retake the working length radiograph. That's how we confirm the radiographic working length in the Ingalls method. Wayne modified the calculation of the working length according to the presence or absence of the resorption. If suppose there is no resorption, subtract 1 mm. If suppose there is a periapical bone resorption, subtract 1.5 mm. And the periapical bone plus root apex resorption, subtract the 2 mm. Now we'll see the non-radiographic methods for working length determination. In this, we'll discuss about the electronic apex locators. It is used to locate the apical constriction or the cemento-dentinal junction or the apical foramen, but not the radiographic apex. So, here, most important factor is the apical control zone. It is that the ability to distinguish between the minor and the major diameter of the apical terminus is the most important for creation of the apical control zone. And it is a mechanical alteration of the apical terminus of the root canal space which provides the arm form to the obturating material against the condensation pressure of the obturation. And in case of the electronic apex locator, we have various components such as the lip clip, file clip, electronic device, and a cord which connects above all these three parts. So how do we use this electronic apex locator? So for this, first what we have to do is that we have to turn on the device and attach the lip clip near the arch being treated and hold a 15 number file and insert it approximately 0.5 mm into the sulcus of the tooth. And then adjust the control knob until the reference needle is centered on the meter scale. And produce the audible beeps which gives readings. So we have to record the readings. If at all this beep sounds or the alarm sound is at the reference point, it will record the length. And if it shows 0.5 mm or 1 mm lesser than the short of apex, it shows the beep with the 0.5 to 1 mm short. And if it is overextended, it will also show the beep known as the overfilling. So, coming to the classification according to the generation of the electronic apex locator, it is based on the direct current or on the alternate current. It on the basis of the direct current, we have the first generation apex locator, which is also known as the resistance apex locator. It measures the opposition to the flow of the direct current, that is the resistance. And it is based on the principle that the resistance offered by the periodontal ligament and the oral mucous membrane is same, that is 6.5 kilo ohms. So the first generation apex locator are the root canal meter, endometric meter, or the dentometer. Coming to the second generation apex locator is nothing but the low frequency apex locator. It is based on the concept of the impedance based apex locator, which measures the opposition to the flow of alternating current. Here, this apex locator indicates the apex when two impedance values approach each other. Example are the Endocator Sono Explorer. Coming to the third generation apex locator or the high frequency apex locator. It is based on the fact that the different sites in the canal give the difference in impedance between the high and low frequencies. The difference in the impedance is least in the coronal part of the canal. As a probe goes deeper into the canal, the difference increases. So it is greatest at the cemento-dentinal junction. And since the impedance of the given circuit may be substantially influenced by the frequency of the current flow, it is also known as the frequency dependent. And the examples are the root ZX mini. Now we'll see the fourth generation apex locator. The fourth generation apex locator measures the resistance and the capacitance separately rather than the resultant impedance value. There can be different combinations of values of capacitance and the resistance that provides the same impedance and the same foraminal reading. So, this fourth generation apex locators are IPEX, Ray Apex 4, Propex are the examples of the fourth generation. But the main problem with the fourth generation is that they can perform well in the dry canals, and it is difficult to use in case of the heavy exudate or the weeping canals. Next generation is the fifth generation or the dual frequency ratio type. To overcome the disadvantage of the previous generation, the fifth generation apex locators have been developed, which is based on comparison of the data taken from the electric characteristics and the additional mathematical processing. So, it shows an accurate reading in the presence of the dry, wet, saline, EDTA, blood, or hypochlorite. Example of the fifth generation is that the Ray Apex, Propex 2, Propex Pixie. And sixth generation is that this is also known as the adaptive apex locator. This apex locator is intended to overcome the disadvantage of the fourth and fifth generation, and it eliminates the need of drying the canals. Example are the Ray Apex 6 and adaptive apex locator. Now we'll see the combination of the apex locators as well as with the endodontic handpieces. The Tri-Auto ZX is a cordless electronic endodontic handpiece with a built-in root ZX apex locator. It has three safety mechanisms. These three are the auto start and stop mechanism, and auto torque and the reverse mechanism, and the auto apical reverse mechanisms. So this helps in preventing the instrument separation or overall under instrumentation. Now we'll see what are the basic conditions required for accuracy of electronic apex locator. First and foremost, it should be free from the most of the tissues and the debris, and it requires a dry environment, and the cervical leakage should also be eliminated. If suppose if there is a residual fluid present in the canal, it should be of low conductive value and should not interfere with the apex locator. And the battery connections of the apex locator should be proper. So this is brief about the working length determination.